I should tell you that in a couple of debates that I've already done with the Health Minister, last night she repeated the claim that they'd opened 2,800 beds since 2005. And I was able to say the real problem for her is that I've been the Shadow Minister since March 1995. And I know that before that date, they'd actually closed 5,000 beds. So that's nothing to boast about. Opening 2,800 beds goes nowhere if you've actually closed 5,000. And that's why it's roughly 5,000, but it's at the moment down about 1,500, and partly now because the government includes bassinets, cots, recliners in the bed count, and even beds in your home if you happen to be a transition patient. I'm not knocking that. I think that treating people in their home is a very useful way of providing better health care. But I don't understand why we then count that bed that you paid good money for in your bedroom has to be included in a bed count related to a hospital. So I think we've got to be more honest about those things as well. So those are my primary focus. And medical research, you probably know that we've released a policy that brings medical research back into the health portfolio. We will still keep the Office of Science and other research separately, reporting to the Minister for Industry, but the Office of Medical Research will be established in the Health Department. It will report to the Health Minister, and I have been able to persuade Mr Peter Wills to set up and chair a task force to develop a 10-year medical research strategic plan for New South Wales, and also we've managed to find some money to increase funds for the medical research support program. And in looking at a lot of these things, I've talked about the need not only to improve our capacity for medical research and support for researchers, but the linkages between universities, institutes, hospitals and those clinicians that are doing that clinical research. I think I'll leave it there, Michael, but I'd be very happy to answer questions, and I know there are going to be many of them.
Thank you, Jillian, for those words. What I'm going to do this time, in a sense of fairness, is to alternate questions from the colleges with questions from the audience, because it's only fair that everyone gets a go. And could I ask everybody, please, to keep their questions concise? Dr. Liz Miles. Oh, sorry, Dr.
I'm happy to be Dr. Liz Miles. I'm Richard Lawrence, actually, from the State Manager for the College of GPs. Listen, I've got to say, Jillian, that general practice organisations were a little bit alarmed when they heard that you were planning to replace them with pharmacists to do their primary healthcare work. There's a lot of international evidence which shows that an integrated primary healthcare sector is very efficient and very effective, but it has to be integrated, and it's particularly successful, according to the evidence, when there's a strong whole of patient, whole of community, medical, clinical leadership at the centre of that integration, which general practitioners currently do. So I'd love to hear actually from your own lips what your real plan is for that integration, especially given the fact that general practitioners and primary healthcare sector, if you build on it, if you build on existing infrastructure, can do a lot to relieve the pressure on hospitals, you know, in relation to admission and discharge, consultation, after-hours care, etc.
Yes, absolutely. And can I recommend that you might, all of you who are interested in policy, look at those policies that are now on our websites. In fact, it points out that that policy we released with pharmacies is about integrating with the pharmacist, with the general practitioner. What we've said is that we'll work with a pharmacy to enable the pharmacy, which is accessible to many people, particularly in small country towns, for example, where there's a waiting list to get into your local GP. It will enable a person to go into the pharmacist, have simple tests, and if there is anything found that needs next treatment, that's straight to the GP. So in fact, and that's spelled out in the policy. I think sometimes the detail gets lost in reducing it to a one-page dot points for press releases, but that is very much the highlight in that policy. I absolutely agree with you that GPs are a fundamental part of the governance and improving patient health care and, in fact, reshaping the health system. In March 2009, I put out a policy called Making It Work, which was about our plans to reform the governance of New South Wales Health. And I talked about abolishing the big area health services, putting in a flatter district structure and creating district health boards. And I say that slowly because they're not hospital boards, they're district health boards. And in describing them in that document, again it's on jillianskinner.com if you want to look at it, I actually talk about the need for those districts to encompass the full range of healthcare provision so that we have a seamless pathway for patients who might want primary health care, and I actually spell out GPs, pharmacists, allied health professionals, non-government organisations, right through to subacute and then acute. And I know that people will come in and out of those systems. That's one of my concerns about the COAG reforms, but I'll address that if anyone has a specific question about that. But rest assured, I know how important a GP and GPs are to the whole system.
Would you please give your name?
Hello, I'm Dr. Elizabeth West. I'm a registrar here at the hospital. My question is in two parts. First, does the Liberal Party accept funding from big tobacco? And the second part being, if that is the case, is it perceived to be a conflict of interest when it comes to health policy, both for chronic disease, burden in the community, as well as burden on acute beds in the hospital system?
Thank you, Elizabeth. The Liberal Party has accepted money from tobacco in the past, no longer, because the Parliament has supported legislation with our support that bans any donations from tobacco, gaming, or, can't remember, there's one other. But so from now on there will be no donations from the tobacco industry. I can tell you, I've been the Shadow Minister for Health since March 95. I have not accepted 1 cent of tobacco money or money from any of those other clubs, pubs, gaming, and that I am the one in our party structure who writes policy. So, you know, the Liberal Party, it's unlike Labor where their state councils, where their bodies actually write the policy. In our structure, I write the policy. I've never received a cent. I want to add one thing to this though. When that legislation came to the Parliament, we've been trying for a long time to reform the donations situation because of course there have been so many allegations of corruption in relation to donations for deals. And we tried to amend that legislation to ban all corporate donations. But unfortunately both the Greens and the Labor Party voted against it. However, if we are elected, Barry O'Farrell has indicated he wants to restore that, return to that legislation, a ban on all corporate donations.
Thank you. Bronwyn Ross from RACMA.
Thanks, Ms Skinner. I'm here representing the Royal Australasian College of Medical Administrators. As you may know, we've been fairly undermined in the last 10 to 15 years in terms of medical managers on executive committees of hospitals. And the role of the Director of Medical Services, who was the primary source of clinician engagement, has been evaporating, as well as all training positions, including the training scheme I was trained on, has vanished. I understand that there are some very important roles played by clinician managers in the new structures, etc. However, as we all know, clinicians are very busy people with very stressful and multiple responsibilities, and we're wondering why the role of the medical trained manager in the executive level of the new structures isn't being adequately acknowledged, and what you might do about that.
Thank you. I'm not very familiar with this whole issue, I must confess, so I'd be very happy to take that on board. That is the loss of the role in the training structures. But can I say, in our Making It Work policy, I've highlighted the need to have clinicians on those boards, and I've highlighted the need to give much greater authority back to the managers of hospitals and other health services. I also acknowledge the need to ensure that clinicians who are trained to provide healthcare, whether they're doctors, nurses or others, and are very skilled in that area, are not always trained to be managers. So I have actually said, particularly in relation to boards, that I would provide board training for those who need it. And I don't think it's just for the clinicians, to be perfectly frank. I was the first woman appointed to a board some years ago, the Police Citizens Youth Club board, actually. When I asked for the financial statements, they said, well, you don't need those, don't worry, it doesn't matter. Well, that's not how I would run a board, and in fact we changed. They had to change because of all this, silly woman who wanted to read financial statements. That will change if I'm elected and we up the ante as far as some of these boards are concerned. I believe that they need to have a real role in managing the system and in understanding all of the obligations that come with that, including financial, including communication with the communities they represent and so on.